and MRI was done, and they found a lesion in the brain. They didn't know what it was. So they did a biopsy. You can see they have raised a flap over here. They have done a biopsy, and that biopsy turned out to be lymphoma. Now, then they sent to us for a PET scan. And when we did a PET scan, we showed multiple lymph nodes all over, inguinal lymph nodes, abdominal lymph nodes, axillary lymph nodes. If they had done the PET scan before, we would have shown them the lymph nodes. They would have taken a biopsy from the lymph node in the axilla and showed that it was a lymphoma. They didn't have to cut open the brain, raise a flap and take out a piece. So using the technology properly, you can avoid morbid surgeries or morbid investigations where we would have been easily told you accessible areas which could have been giving you the same diagnosis. Here was a 40-year-old male with headache and reduced vision. MRI showed no orbital pathology or nerve compression. We did a PET scan and look at these abnormalities over the brain. These are all hot areas over the surface of the cortex, and we found multiple lymph nodes here in the mediastinum. This was a case of sarcoidosis, very easily picked up on a PET scan with CNS involvement as well as the classical lymphadenopathy occurring in the mediastinum. And in India, TB is a big problem. If you have lymph nodes, it could be TB, it could be lymphoma, it could be sarcoid. So on a FDG PET, everything will look hot. So how do we distinguish between the two? Here we have a new agent called fluorothymidine. The thymidine is incorporated into the DNA. Proliferating cells pick up thymidine. So in tuberculosis, there is no proliferation. It is aggregation of cells. So our hypothesis is that in TB lesions, FLT will not go. While in malignant lesions, where there is proliferation of the cells, FLT will go. So here you have a patient who has got tumor as well as infection in the same setting. And when we do a FDG scan, the infected lesions pick up glucose, the tumor picks up glucose. While we do a FLT PET scan, only the tumor picks up glucose and the infected lesions do not pick up glucose. So here is an open case of TB, diagnosed TB, where FDG is very, very hot, but FLT is not showing any uptake. So we are discovering a new tool where we can distinguish in a given patient whether the lesion is malignant or it is because of infection. And when this becomes validated, we'll have a powerful tool to distinguish malignancy from an infected pathology. Here was a young fellow who was presented with cough and weight loss. He was sent to us for a PET scan. Look at the abnormal uptake in the lungs. He's got studded with metastasis in the lung. He's got all lymph nodes in the abdomen. But where is the primary? You can look down into his testes. Here is a small hot spot here. This was a testicular tumor which has metastasized all over to the lungs and to the abdomen. And when the treatment was given, you can see post-treatment, all these lesions have just vanished. So you have a powerful tool to diagnose malignancy, to see where it is, unknown primary. You can diagnose infection, you can diagnose sarcoidosis, and you can follow up. Here is a patient with cecal cancer with metastasis. After chemotherapy, all these lesions have vanished. And then after some years, he comes back with a recurrence. So at all stages of cancer, we can use PET-CT to diagnose it, to see if your therapy is working, and to see if the recurrence has occurred. In the past, we had to do all cycles of chemotherapy. After 6 months, patient has lost all his hair, he's lost weight, then you realize chemotherapy is not working. Then you switch to something else. Now with a PET scan, after 2 cycles of chemotherapy, we can show that the metabolic response is there, your chemotherapy is working, continue with it. If there is no metabolic response, you can tell this chemotherapy is not working, switch over to something else. So you will prevent the patient from suffering all the side effects of chemotherapy and have no benefits as opposed to giving the proper management. So again, sarcoidosis, pre-therapy, post-therapy, you can see all those lesions have vanished. And now we have new tracers coming up all the time. All of you have heard of insulinomas, carcinoids. These are very difficult to diagnose. Now we have agents which can image these very well. All these tumors like neuroendocrine tumors express somatostatin receptors. And we have agents to label them. Here was a patient who was having diarrhea, lot of diarrhea, unexplained diarrhea. And when we did a gallium DOTATOX somatostatin PET, we located a nice duodenal lesion, which was a carcinoid, which was causing the diarrhea. And not only can we diagnose it now, we can treat it with lutetium. So the last slide tells you that nuclear medicine is not only about diagnosis, it is also about treatment of several diseases. All of you know about Graves' disease, where we give radioactive iodine, we treat thyroid cancer. If you have painful bone metastasis, we can treat them with special radioisotope which go and destroy these metastases. We can treat painful joints. We can treat neuroendocrine tumors, as I already told you, and we can also treat few cases of hepatomas and hepatic mets. I think that's the last slide. I thank you for your attention.
I congratulate Dr. Lele for giving nice lecture. Session is open for question. Are there any questions? Dr. Lele, what preparation we should do for the before sending PET scan?
Well, usually we want the patient to be fasting for at least 6 hours. And if he has got diabetes, it has to be controlled because the natural sugar competes with the radioactive sugar. So if there's too much high sugar, my radioactive glucose will not go into the lesion. So it has to be completely fasting. That's about it. 6 hours fasting.
6 hours fasting.
Yeah.
What about diabetes then, if a patient is a diabetic?
If the patient is diabetic, then we want the diabetes to be controlled. The sugar should be less than 200. Up to 200, we get diagnostic quality scans. If it is above 200, we usually make them wait in the department, give a shot of insulin, a small one, wait for the sugar to come down and remain stable, and then we inject the radioactive glucose.
How affordable are these studies? Because in periphery, we have to counsel the patient for if he is going for a expensive investigation. How affordable are these studies?
Well, it is an expensive study. The whole body PET CT costs 21,000 rupees. But for deserving patients, there's always a concession which can be given. But as I told you, most of these patients already come with the whole body CT done. They've already spent so much money, and then they are coming for this. So especially in fever of unknown origin, this would be probably the best to do right in the beginning and avoid too many investigations. Single investigation will give you the answer.
So do you say that we should do first PET scan and then others?
In a real PUO, most of the time you'll get your diagnosis, malaria, the usual ones. But if you're at your wit's end, yes, this will be the single best test to sort out your issues. And a normal FDG PET in a PUO has excellent prognosis. That means you're not dealing with anything serious. It's usually a self-limiting drug fever or a viral infection which has run its course. Yeah. Otherwise, some focus you'll find, you can take a biopsy from there.
Yeah. Suppose the patient gets a myocardial infarction and was thrombolized. So what patient should we send for stress thallium? Should we send all patients who are thrombolized for stress thallium and then go for angiography? Or where should we send?
See, if he's already got an infarct, there are two things. If his ejection fraction is fairly good, and you have done an angiography, I presume, already.
No, the question asked was angiography is not done.
Okay, angiography is not done, and the infarct has occurred. It will be a good idea at the 6 weeks, after 6 weeks of resolution of the infarct, to go for a myocardial perfusion scan. Because then you will know if they are outside the infarct zone, if there are any other areas of ischemia present or not. We will categorize the patient as high risk, low risk, intermediate risk. If I get a high risk pattern, post-thrombolytic patient, you must go for an angiography and further intervention. If I get a low risk pattern, it's fine, manage him medically. Sorry, in the field of psychiatry.
Yes, sir. We are
Yeah.
labeling today the many patients schizophrenic, but they may be showing some abnormal brain metabolic patterns and which may be labeled as some disease. And today we are treating them as a schizophrenia.
Absolutely. Now, this is still an area of research. It is not a very established, but we are finding very interesting pattern. For example, in depression, a patient who is depressed, we tend to find frontal and lateral frontal hypometabolism, sometimes even involving the temporal lobe. Here you have an objective evidence that something is going wrong. In depressed patient, this has been a consistent finding. And when you treat the depression, these areas of abnormal metabolism disappear. In schizophrenia, they tend to have a hyper-expression of dopamine receptors in the basal ganglia. And if you and me are told to perform a mental task, your frontal lobe lights up immediately. In a schizophrenic, paradoxically, there is a fall in the frontal metabolism when he's asked to do a mental task. So there are several interesting cases which are turning out to be specific for separate psychiatric disorders. So the research is going on. Nothing has become absolutely established, but there are areas where we can help you in making at least pointing you in the right direction.
Thank you, Dr. Lele, for nice illustrative talk on nuclear medicine, and I also thanks audience for the interaction. Should
I-
continue in future next coming lectures also. Thank you, Dr. Lele.
I request Dr. Kanfade sir and Dr. Godeswar sir to felicitate Dr. Vikram sir with memento. I request Dr. Deepak Agrawal sir to felicitate Dr. Kanfade sir and Dr. Godeswar sir. Our next lecture is on significance of AVR lead in ECG. For that, I would like to request Dr. Hashish Bajaj sir and Dr. Durgesh Mahajan sir to come on dais. Dr. Hashish Bajaj sir and Dr. Durgesh Mahajan sir.
Hi, good morning, everybody. Now we will have an interesting discussion and presentation on significance of AVR lead in ECG by Dr. Sachin Suryavanshi.
Dr. Suryavanshi is excellent teacher, and he is always a source of inspiration for us. So it will be quite beneficial to us to his talk. We welcome Dr. Suryavanshi for a talk. Thank you.
Honorable Chairman, sir, Honorable Co-Chairman, respected delegates, my teachers, we are extremely thankful to Dr. Vikram, who has given us a beautiful review of a very high-end machine with extremely important applications. What I am going to talk is on a very basic machine which has always stood the test of time since a century, and it has never gone in museum in any place. Only it has changed the form. It has never gone in museum. That machine is the ECG machine. If we go to the history, documenting the electrical activity of the heart, the first attempt was done by Alexander Muirhead, who was doing DSc in physics, and he recorded the first ECG with the help of Lippmann's capillary electrometer. The first systematic approach was done in 1911 by Augustus Waller, and the first commercial apparatus of ECG machine was available, which was separately invented as a string galvanometer by William Einthoven as well as Clement Ader independently. Friends, as Albert Einstein said, intelligence lies not in the stock of knowledge one possesses, but in one's ability of imagination. Perfectly in keeping with this is the first ever ECG machine which was commercially available, made by William Einthoven in 1911. I would like to attract your attention to two things here. See that there are three vessels here. One is this vessel, another is this vessel, and third is this vessel, which all of them contain water, and the limb of William Einthoven is dipped in these three machines, right upper, and the left lower, which are acting as electrodes. Here is a camera, which is a photographic camera with a rotating photographic plate, which records the ECG, which is generated with the help of a string galvanometer. So this ECG machine was the first one. We are thankful to William Einthoven, who is the father of modern ECG practice currently, for the waveform which he has given, that is PQRST, and also for the hexaxial system on which we calculate the axis of the heart. Here in this diagram, I would like to remember that there are three dimensions of this figure. One is of the AVR, which is looking at the heart through the right shoulder, through the right atrium. Another is AVL from the left shoulder. And third is 2-3 AVF, which are looking for the inferior portion of the heart. And these are grouped together. This is forming one group. AVL with V5, V6 is forming another group. V3, V4 is forming another group. And V1, V2 are also forming another group. These are separate groups on the basis of which we found our ECG diagnosis. V1 to V6 are also known as Z-axis, which are horizontally placed, and rest of the leads are on the frontal plane. Next came the big discovery by Goldberger, who invented the Emanuel Goldberger's leads. These are the unipolar limb leads, AVR, AVL, and AVF, derived from basic leads 1, 2, and 3, which viewed the heart from different angles and planes. Next came the discovery of Wilson's central terminus, which invented a common resistance path for the two electrodes against which one electrode can be compared, and he called them as augmented limb leads. In chest, the WCT is formed by combination of 3 limb leads which go through the same resistance. This paved the way to the augmented unipolar limb leads with AVR, AVL, and AVF. There is a quantitative or mathematical relationship between these leads which was shown by William Einthoven as well as Wilson, where AVR is equal to this equation and is also equal to 1 plus 2 divided by 2. So there is a mathematical relationship between all these leads. We will not go into the mathematical details. It was the introduction of these 3 leads. Previously, in the beginning, the ECG was only of 3 leads, which was done by William Einthoven. Later on, the ECG became of 6 or 9 leads when V1 to V6 were invented, and now it is this 12-lead ECG, the introduction of these 3 leads, which Goldberger's leads, which make the 12-lead ECG. An important concept which I want to deliver here is a concept of cavity complex. RA electrode is expected to view the heart from shoulder along the right superior vector through and including RA. It images the outflow tract of the right ventricle and posterobasal interventricular septal tissue. If you look at this figure carefully, we know that the blood supply of the heart is directed from outside to inside, whereas the electric supply of the heart is from inside to outside. Therefore, any electrode which is kept on the surface of the heart will see the impulses coming towards itself, and it will record a positive wave, as is occurring in these 3 leads. But an electrode which is dipped inside the cavity of the heart sees that all the impulses are going away from it, and therefore it will record a negative complex. In case of myocardial infarction, this area is electrically dead, therefore we call it an electrical window. An electrode which is kept on the surface of this will see what is happening inside the cavity because it is an electrical window, and will record a negative complex. This is what we call as a cavity complex. A right atrial lead is also known as a cavity complex. Why is AVR often ignored? We all look at the ECG very carefully, but AVR is not so carefully looked by us in most of the instances. At least it was true in my case. So here, why is AVR often ignored? The concept of contiguous leads. You can see that those which are labeled green are lateral, lead 1, AVL, and V5, V6, which we call as anterolateral, V3, V4 as anteroapical, and V1, V2 in the same pink color as anteroseptal. Here, Lead 2, 3 and AVF we label as inferior wall. If I take it on the ECG, then here the ECG also is labeled in the same color, lead 1, AVL, V5, V6, lead V3 and V4, V1 and V2, and 2, 3 AVF. In all these, both these circumstances, what is remaining unpaired with anyone is the lead AVR. Let us go ahead. Taken as a lead which just displays the information reciprocal to AVL, to V5 and V6, hence taken as redundant, therefore ignored even while analyzing the complex ECGs. Therefore, we visited AVR while searching for ECG evidence in non-STEMI TROP-I positive cases, accepting that the ST deviation in AVR need to be addressed in its own account, in its own right, particularly in the background of other evidence of acute coronary syndrome. Therefore, we relearn AVR here. AVR waveform behavior in different clinical conditions became the area of interest with several interesting revelations thereof. Angeline et al. In 1999 was the first person who pointed out that it is a useful tool to predict the site of occlusion of left coronary artery circulation, occlusion. This is a diagrammatic representation of the coronary circulation, LAD, RCA, and circumflex. The culprit vessel in anterior wall myocardial infarction can be left main or it can be left anterior descending artery. Here the diagnosis of anterior wall is done by precordial leads, but remember that attracting your attention to this sentence that the site of LAD occlusion can be from the limb leads only. Let us go ahead. This is a left anterior descending artery and this red dot indicates the block in LAD. The area, as proximal is the block, that maximum is the damage. As proximal is the block and the coronary angioplasty is in that situation, that maximum is the benefit acquired out of that angioplasty. Therefore, one has to identify as to where is the block. Here the block is proximal to the first septal perforator and also to the diagonal. If you see the damage done, it is an extensive damage done to the myocardium. In the horizontal section also you can see the damage done. Here the AVR is elevated, AVL is also elevated, but 2, 3 AVF are showing ST depression, as is V1 and V2, whereas V5, V6 are showing ST depression. Coming next, here proximal LAD occlusion causes ST elevation in AVR and AVL, ST depression in lead AVR and some ST depression in elevation in AVL. ST depression in lead AVR and sometimes in AVL, ST elevation in V6 and sometimes ST depression in V1. Let us see the ECG here in proximal LAD occlusion. This is the distal LAD occlusion where the occlusion is present distal to the diagonal artery and the damage done is comparatively smaller as compared to the proximal occlusion, and this is the occlusion. Here 2, 3 AVF are showing ST elevation in distal occlusion, whereas AVR is showing ST depression along with AVL. The elevation here is maximum in V5, V6. Coming next, in distal LAD occlusion, you get ST elevation or isoelectric ST elevation in 2, 3 AVF, ST depression in AVR and sometimes in AVL, ST elevation in V6 and sometimes ST depression in V1. These are the two ECGs. You will carefully look here that LAD occlusion proximal and distal. Here there is a ST elevation in AVR, ST depression in 2, 3 and AVF, ST elevation in V1, V2 and V3 and depression in lateral precordial leads. This is proximal, and when you come to the distal, here is ST depression in AVR and ST elevation in these precordial leads. So differentiation can be made between proximal and distal. If you look at AVR, ST elevation in AVR is a bad prognostic sign showing proximal occlusion, whereas ST depression in AVR shows distal occlusion. Proximal LAD occlusion, ST elevation in AVR, non-STEMI left main and triple vessel disease or equivalent of triple vessel disease is also important. Here ST depression, when you see the triple vessel disease, you find that most of the leads, more than 8 leads are showing ST depression. ST elevation in AVR and V1. And here the ST elevation in AVR is more than that observed in V1. When this is the situation that ST elevation in AVR is more than in V1, it indicates that it is a primary occlusion of the left main disease. ST depression is present maximum in V4, V5. All the leads are showing ST depression, but ST AVR is showing ST elevation more than V1. That goes in favor of proximal occlusion, that is occlusion of the main coronary artery, left main coronary artery. This is after the patient became normal. Here the coronary angiography, which shows that there is a severe left main disease or a left main equivalent. So left main equivalent or left main disease can show that there is ST elevation in AVR more than V1 and severe ST depression including V4. V4 shows the maximum ST depression. Gaitonde RS were first to point out that ST elevation in AVR exceeding that in V1 is typical of LMC occlusion. Sensitivity is 81% and specificity 80%. Prospective study of 201 cases showed that ST elevation in AVR more than V1, outcome is poor and more patient needed to be referred for CABG. In this situation, a practitioner has to withhold clopidogrel because the patient will have to be referred for CABG. Another ECG is showing ST elevation in AVR. These workers said that this is the strongest predictor of serious adverse events in hospital, mortality as well as 90 days mortality and morbidity. 775 cases follow-up by Barabis also showed the same thing or similar things. One thing I want to here point out to all of you that here, if you take this vector from -60 to +120, if the ST elevation is directed in the leads coming in this vector, that is 3 AVR, then this becomes a high-risk ischemia vector. ST elevation in this vector will indicate that the patient has got poorer prognosis. It's a beautiful study done by Zymanski of 205 cases in which they have studied an ST elevation of 0.5 millimeter or more in AVR. These 205 cases were 114 showing ST elevation and 91 were not showing ST elevation. If you look at those who survived, 187 patients survived and only 18 patients had died. Out of these 187, almost equal number of cases were showing either ST elevation or ST depression or no ST elevation, whereas out of 18 who died, 16 had ST elevation and only 2 did not show ST elevation in AVR. So amongst 187 survivors, ST elevation in 98, that is 52%, and no ST elevation in 89, that is 48%. The difference is not significant. But among 18 deaths, ST elevation in 16 and no ST elevation in 2, the difference is certainly significant. Here, if you come by knowing the severity of ST elevation in AVR, here it is 0.5 millimeter, 1 millimeter ST elevation in AVR, 1.5 to 2 millimeter, and 2.5 to 3 or more millimeters of ST elevation in AVR. Here, the distribution of cases, the mortality in this case is 10%, here it is 13%, here it is 22%, but here if the ST elevation is severe, then the mortality is almost 50%. Though the number of cases is small, the figure is significant and worth studying. Similarly, AVR is also helpful in the diagnosis of acute pericarditis, which you call as knuckle sign. Pericarditis produces subepicardial injury. There is global or almost global ST elevation or PR depression. It comes to the differential diagnosis of AMI, but PR elevation and ST segment depression in AVR is called knuckle sign. So kindly look at this ECG that there are ST elevation globally in all the leads in this ECG with concavity upwards, which is popularly known as Pardis sign. But see the AVR, here the PR is elevated, but ST segment is depressed. This is known as PR elevation in ST segment depression in AVR is called knuckle sign positive, also seen Pardis sign in all other precordial leads. In arrhythmias, presence of positive P wave in AVR indicates AVNRT. This P falls after QRS or at the end of QRS. Look here, this is called pseudo elevation, where the P wave is falling after the QRS at the end of QRS complex, which goes in favor of AV-NRT during the attack of AV-NRT in panel A. This is panel A, and this is panel B, where the AV-NRT has reverted to normal sinus rhythm, and the sign which is seen in AVR has disappeared. Brugada's algorithm is used for diagnosis of VT. Similarly, Verreke's algorithm is used for VT as well as for diagnosis of VT based upon AVR alone. If you look at AVR alone, by looking at AVR alone, if you answer these 4 questions as yes, here you see very carefully that